having meetings that are back to back and on top of each other. So hopefully we will have more of our committees members show up. All right, first on the agenda, House Bill 537. Representative Rogers.
Thank you, Madam Chair. Members of the committee, I present to you House Bill 537. For you new members, you probably don't remember this. This is our third time of trying to fix what I feel like is a problem. This bill does something simple. It applies to the wisdom of the private sector by letting the state run its own contracting process to provide dental coverage to children in Medicaid and peach care. Right now, the state hires CMOs to provide both medical and dental coverage. CMOs are case management organizations. I think it's 11 years ago, the former governor passed a bill that dealt with case management organization, and we have recognized, a lot of the representatives and senators have recognized that the dental issue continues to be cut through the CMOs. These CMOs are like HMOs operating under a different name within the Medicaid world. Just like any other HMO, they do not provide dental insurance. Such must subcontract with dental insurance companies to handle the dental benefit required by the state Medicaid contract. However, like any middleman, CMOs keep a portion of the fee before passing it on to the dental insurance company that actually provides the benefit. In fact, we will discuss the fee kept by CMOs. I won't do that today, but it has been substantial over the years, running in the tens of millions of dollars. Under this bill, the state would remove the middleman and run its own contracting process for the dental benefit of Medicaid and peach care. This bill requires the process to be competitive bid and puts the dental insurance company fully at risk, just like we require the CMOs. The CMOs themselves will compete for the business as long as they actually provide a dental benefit and do not subcontract it out. The CMOs are not doing anything wrong. They're doing what the contract put in place by then Governor Perdue allows them to do. Get a fee for dental coverage, subcontract the dental benefit to another company, and keep a portion of the fee for running the contract process on its own behalf. It is what any company in a similar contract would do. The problem is, with the plan design, Georgia Medicaid is trying to do what almost no one in the private sector does, which is put medical insurance and dental insurance in one bundle. Medical insurance and dental insurance are different. They're not apples and oranges. They're more like sweet peas and cantaloupes. By forcing medical and dental insurance into one contract, the way Georgia currently does, we are creating a structural inefficiency that costs the state millions of dollars. Figures that I have seen as much as $80 million to force medical and dental in the same contract. In fact, payment figures indicated by the CMOs were keeping as much as half of the money they received from the state to provide dental services before they ever sent it along to the dental network. Georgia could save tens of millions of dollars that could be used to help with the budget and keep dental providers actually serving children. DCH itself handles medical and dental insurance directly and separately for the state health benefit plan. We believe that the state should follow the same example of the private sector and the example of DCH on state health benefit plan and do the same direct contracting for dental within Medicaid and peach care. To be clear, we were held off several years ago because of the present governor and his administration wanted it to kind of settle in or settle out, and we accepted this position in good faith, and we will continue to work to resolve any concerns that the executive branch has. However, there must be a change in the program if we are going to make it as efficient as possible and free up resources to allow dentists to actually serve children rather than have that money absorbed by the CMOs. And the truth of the matter is we cannot wait. Give you an idea, there are 10 states have already done a dental carve-out. I know Louisiana's done one, Texas has done one, South Carolina, and now Tennessee, and I think Virginia's in there as well. So Be glad to try to answer any questions if there are any. Other people will speak, professional people that are in the business, and I'd rather them come to the mic than me.
Okay, first one. Any questions for Representative Rogers? No questions for
Thank
you.
you.
Okay, Dr. Brooks? When you come to testify, if you'll identify yourself and tell us who you're with, even if it's yourself, Dr. Brooks.
Thank you. First of all, let me say we appreciate the opportunity that y'all have provided us to come to express some of our experiences in the dental office with the current setup of CMOs. We have 3 CMOs plus the DCH administering Medicaid and Peach Care for kids. It's quite a cumbersome system. For example, in the office, we have 4 manuals that we have to look through to find out if a particular service is covered. These manuals are not, yay thick. They are like 3 to 4 inches thick. I have 2 full-time people and 1 part-time person that does this in my particular office. This filters down to patients. Patients have to wait for us to research this to see if a particular filling is covered or if a particular extraction is covered or anything else. The CMOs reimburse us at different rates at different times. For example, fluoride treatments, some of them reimburse us every 6 months, some twice a year. You think that's the same, but it's not. You have to read the fine print in those manuals. We have 4 different web portals that we have to go to verify eligibility for a particular recipient. Eligibility has to be verified every 30 days. It's strictly on a monthly basis. If you don't verify eligibility, you don't know whether that person is covered or not. A lot of times, the mother of these kids, I don't know whether they don't understand or they choose not to understand why you cannot provide a certain service for a particular kid. But that happens, and it's tough to explain. Sometimes it's unexplainable. We have a lot of detail to go through when we pre-authorize something. Some procedures are not automatic. They have to be pre-treated or pre-authorized. That creates another problem with the patients. The patient has to wait. The mother or father has to understand why they have to wait. And this is not an easy subject to explain to them. Not easy at all. I'm a general practitioner from Blakely, Georgia, which is down in the southwestern corner of the state. We are in a very populated, Medicaid-populated area. We see a lot of Medicaid patients in my office. My office is about 35% Medicaid. We see a lot of patients. I am one of the very few providers for orthodontic services in southwest Georgia. Now, orthodontics is one of the specialty areas, and it's just recently become one of the covered services through Medicaid and Peach Care for Kids. 5-6 years ago, maybe it came in. We have 4 entities that have 4 different sets of criteria to approve these kids for braces. It's awfully hard for us to explain to a mother why her kid does not get braces or doesn't get them paid for when their neighbor has braces on that we put on that are paid for. It's hard to explain to them. Going through these different criteria, it's a tough job to do. The patients have to wait. The patients don't understand. And if a patient has a crossbite, which means the front teeth interlock instead of overlap like they should, the kid cannot chew. Well, this is not a covered criteria under any of the CMOs. We have managed to get a few approved for that, but you know, that's a crying shame when a kid cannot chew properly, and it's just not a covered service. If we go to a one-payer system, maybe we can improve this situation. Thank you for your attention.
Okay, Dr. Brooks, so, you know, what I'm hearing is I saw a list of how the different CMOs pay different rates within a few dollars, but it sounds like to me that even more than that few dollars discrepancy, it's the hassle of 3 different portals or 4 different portals and all the different rules and having to hire 2.5 staff members to handle it.
That's exactly right.
And that interfering with your ability to treat patients when you're in an area like Blakely. Is that it?
That's correct.
In a nutshell?
It slows treatment down. It prevents a lot of treatment.
Okay. Thank you. Representative Henson, do you have a question for Dr. Brooks?
No, I just want to make a statement to your statement. And having run the front office of a dental practice that is heavily Medicaid, it is very complex and confusing. And I think the best example that could be used that makes it very, very understandable is what Dr. Brooks, mentioned was the difference between cleanings every 6 months or twice a year. And that becomes very, very complex because seriously, if you bring a child in, if it's on a 6-month basis, you bring a child in 1 day early, you don't get paid for it. 1 day. And it's having to watch every single little item, not just the treatment of the patient, but every little insurance thing. And it'd be wonderful not having to deal with multiple ones. And also it's multiple contracts that the dentist has to sign up with, which gets very, very complex. Because even if you've been in something before, the sign up, even if you're in practice for 30 years, if you're signing up new for something or you come in, they're treating you as though you've never practiced dentistry before. And it's just ominous, the sign up into a new category. And I hope that when we finally go to a point of a carve out and one provider, that these dentists don't have to go through this incredibly intensive sign up if they're already a provider for Medicaid or Peach Care.
Okay. Any more questions from the committee? Okay, well, we have other people that want to speak. So if you, we have a lot to do and the hour is late, so we'll keep it succinct. Dr. Shealy.
Hi, I'm Dr. Jim Shealy. I'm a pediatric dentist in Northwest Georgia. I have offices in Cartersville, Georgia, and also Rome, Georgia. Thank you, Madam Chairman and committee members, for giving me the opportunity to speak also. I'm a GDA member as well. Being in a relatively rural area, I see roughly 80 to sometimes 120 Medicaid patients a day in our practice. I was one of the first pediatric dental practices in Northwest Georgia to accept Medicaid, and we've been plowing through it, let's say, for the past 15 years, and really happy to treat that population. My services, I think, make the most difference for those kids. A lot of these children, just briefly, come to me, 3- and 4-year-olds that last week I did a case in the OR that required 18 extractions. So it's, yes, on a 3-year-old. So
on a 3-year-old?
This is correct. So this is the sort of thing that we're talking about. These are the type of cases, the kids that need care. So it's not a matter of one little filling and that sort of thing. And it makes a difference in these kids' lives because they then can sleep better, eat better. When they get to school, they can pay attention better. So it's very important that children in these underserved areas have access to care. I'm going to repeat a lot of what Dr. Brooks has already mentioned as far as the difficulties in the office administering these plans. But you can imagine in an office that busy with a 3-year-old waiting to get x-rays, but yet the young lady that's helped the assistant has to go check on benefits, how difficult it is sometimes navigating the portal systems and figuring out with this insurance company, whether or not the child is eligible. And sometimes it's not even a matter of, can they have x-rays? It's sometimes these children, as a specialist, come from other offices, and I don't know what's been done at the other office, so then we have to go to the portal and try to figure that out as well. So it delays treatment, of course, causes the office to run behind, that sort of thing. And I too have, it takes on the average of two staff members a day to keep a handle on all of the benefits and manage the insurance, the CMOs, as far as eligibility is concerned. One other thing I wanted to talk about was patient eligibility, if they're eligible or not. You know, every day, if you can imagine, again, 80 to 120 kids, we have to go through, one of the young ladies at my office has to go through every day and verify and make sure that the people coming, especially at the beginning of the month, it's a problem, you know, that the patient is eligible. They may have an appointment, but for some reason they may have allowed their insurance to lapse. And we have to spend time trying to figure out if they're still eligible or not. If they've changed CMOs, there's a 5-day window there where they can't receive care. So that causes a problem because there is such a need. If that patient has an appointment, shows up that day, and we're not able to see them, then that's an appointment that some other child could not have, that some other child could have received care. So just in summary, again, most of what I had to say reflected what Dr. Brooks has already said. If there were a simpler system, something that was more manageable, I think other practitioners would be more receptive to signing up, and those of us that are fighting the good fight in these rural areas in particular would have some help with treating these kids and making sure they have adequate care. Thank you very much.
Okay. Are there questions for the doctor? Okay, we have one. Representative Petrie.
Yes, Doctor. Obviously, some of the issues y'all have spoken to, bureaucracy, low rates, et cetera, absolutely have an effect on supply. And so can you tell me where we are statewide with the availability of dentists to serve children in Georgia today? Are there areas where we really have a dearth of providers? And can you speak to that, perhaps, or can someone in your delegation?
I can't speak specifically. I don't have the numbers. The GDA probably has specific numbers. I can tell you in my neck of the woods, I think I could probably name 4 of us that are handling Northwest Georgia from Cartersville up to the Tennessee-Alabama line. So not a whole lot.
Yeah.
Okay, thank you.
Thank you.
Any other questions, committee? Okay, thank you very much. Mr. Frank Capaldo, okay?
Madam Chair, members of the committee, thank you for the opportunity to address you on this House bill. First of all, my name is Frank Capaldo. I'm the Executive Director of the Georgia Dental Association, and we're here to support House Bill 537. House Bill 537 offers a fiscally sound way to save the state money and ensure more of the funding available for dental Medicaid goes toward paying for care and not the administrative costs of care management organizations. Not one of the 3 CMOs has the capability of managing and paying dental claims, and thus each of the CMOs subcontracts out their dental Medicaid program to a separate organization. Because the CMOs subcontract the dental Medicaid program to a third party, the state is unnecessarily paying multiple layers of administrative costs and profits. 6 different companies' administrative costs and profits are to be paid before any money is available to fund care for Georgia's children. In 2013, AmeriGroup's second quarter administrative costs and profit were 17.49%. Peach Care's 9.99%. WellCare's 10.63%. Add to that administrative cost for the subcontractors of DentaQuest, Scion, and Avisis, which is approximately 10%, and we are paying 20 to 27% on administrative and profits. Now, when the state did this, it was 3 to 5%. When you go out to the market and do it commercially, it is less than 8%. It stands to reason that removing unnecessary middlemen saves money. This is exactly what House Bill 537 will do. Eliminating the CMOs, each of which subcontract with different companies to administer dental benefits, may allow the state of Georgia to realize a savings in administrative costs and profit fees. In the packets that we gave to you, you will find a document that was provided to the legislator in 2010 when you were all considering House Bill 1407. That shows that a single administrator would save the state $70 million even if access for children increased by 12%. Another point which bears emphasis is that by implementing a single administrator, more dentists would be encouraged to participate as Medicaid providers. Representative Petrie, I think this next comment will address yours. As a result of the administrative burdens and the multiple provider cuts, we have gone from having over 1,585 dentists accept Medicaid in 2001 to a measly 752 in 2010, and it's not getting better. We need to reverse this trend. At least 10 states utilize a single administrator for dental benefits. I'd like to give you two quick examples. Tennessee switched to a single administrator carve-out in 2002. Tennessee made the change because participating dentists dwindled from more than 1,700, sound familiar, in 1984 to just 386 general and specialist dentists. The more than 600,000 Tenacare, similar to our Peach Care, eligible children in 2001. That's how many there were, 600,000. As of June of 2004, a remarkable 700 dentists were once again participating in the program. This was achieved while dental spending remained at only 2% in the overall Medicaid budget for Tennessee. Excuse me.
We have a long way to go, so if you can be succinct and...
I apologize, but
Okay.
the same took place in Virginia. The same kind of results that we saw here by the carve-out that I've explained to you. So, in closing, I want to respect your time and thank you. If you have any questions, I'm happy to receive them.
Any questions? No questions. Thank you very much. Dr. Coley? Yeah.
Thank you, Madam Chairman. My name is Byron Colley. I'm humbled to speak to you today and represent the Georgia Dental Association. I want to thank each one of you for your sacrifice. You make away from your family, your profession, to serve the citizens of Georgia. I've been practicing pediatric dentistry in Savannah for 15 years. So I've seen the transition from state-run Medicaid to CMO-run Medicaid. I'm the third generation to practice in this practice. This has been serving patients since 1940. We've been Medicaid providers since Medicaid started in the state of Georgia. I'd like to discuss a few of the issues we face in our practice on a daily basis that restricts providers from being able to perform dentistry at a standard of care that benefits the patients. Since these organizations have taken over, reimbursement rates have dropped and rules and regulations have increased. I really want to discuss the rules and regulations changes that we encounter. Things like lifetime maximums for procedures that are performed. Things like limits on procedures that can be performed, not allowing treatment the same day as an emergency exam. So if a child comes in pain, abscess, hurting for a couple of days, we can't perform treatment on that day. This is what has made dentistry such a wonderful profession. The dentist can take care of the issue, the pain, the day of the appointment, and the child doesn't have to seek treatment from hospital where the antibiotics will be given and no treatment to get the child out of pain will be done. Prior authorizations, charting system for patients to be treated in the operating room under general anesthesia. These charts and systems are unachievable point accumulations for these children. Age limits for procedures, the use of nitrous oxide, which helps calm the patient when they're getting dental treatment done. Many of these issues vary between the CMOs. There are two issues that I'd really like to discuss here, and that's eligibility and inability of the patients to have a dental home in their community. A dental home is somewhere where a child can go to have an examination, to be looked at by a dentist and determine where the pain is coming from. Eligibility has been an issue since the CMOs came into play. The state determines eligibility, and the CMOs may not receive updated information for days after the beginning of the month. So if a child is dropped off of Medicaid, they go back into the GHP portal, and then for 4 to 5 days, the child is not eligible for treatment under the model of the CMO. This causes problems for our office in terms of filing claims to the correct company and then having to refile when they are denied. When websites are down, checking eligibility becomes impossible for an office like ours. We see almost 67% of our patients are Medicaid. And that's where I practice in Savannah. These children come for 2 and 3 hours to our practice. The fee cuts that have been have resulted in practices dropping out of Medicaid or not seeing these patients at all. This is a serious problem in the rural areas because this is where the dental treatment is needed the most. Not only can the children not be seen in their community or their dental home, but now they have to wait an extended amount of time to be seen in our office. Extensive treatment times like 3 to 6 months, long waiting time for the hospital. This long wait time for a child results in extraction having to be done instead of dental treatment done in a dental home. These issues are why the GDA supports a single administrator. This would streamline the program, and the money paid out to these 7 organizations could be used to pay a single administrator, which would leave an excess of money to be spent treating the dental needs of the children that need it so desperately. I thank you for considering this bill, and if it passes, I hope the GDA can be involved in discussing who will be the single administrator. Thank you.
Thank you. Any questions for Dr. Cullen? Okay. Thank you very much. Thanks to the dentist, to all of you, especially the pediatric dentist. If your patients cause you as much trouble as I caused my dentist at age 12, I pity you. It's a surprise we have anybody. Of course, I haven't had a cavity since I was age 12 either. He got me. So thank you for your service and for taking care. And with that, Blake, you want to come on up and present the other side?
Good afternoon, Madam Chair and members of the committee. I will be extremely brief this afternoon, but I wanted to hit on a couple of points I know that have been raised today.
And you are with?
I'm sorry. I am Blake Fullenwider, and I represent a coalition of Georgia's 3 managed care companies, Peach State, AmeriGroup, and WellCare. I wanted to hit on a couple of points that have been raised, and one is on cost. I've heard an $80 million potential savings. I'm not sure where those figures come in play. The reality from this perspective is that if the state were to keep everything else the same and were to bring in an additional dental-specific administrator, then that's one more contract that the Department of Community Health would have to administer and manage on their own. So that's going to require resources on that front. We'd be happy to look at any estimates of savings, but I just want to make a note that we're not familiar with the origins of those. And I also want to talk about the issue of CMOs taking benefit of payments that are made to some subcontractors. And I just want to lay out sort of the mechanics of how capitated managed care work. There is no specific allocation of money for dental services. It's all part of the global capitation payment that is paid to the 3 CMOs, which is set by the state and the federal government. We, as Georgia, we have been at the bottom of that capitation range since this program was incepted. So there's really no downward movement that the CMOs or the state can go without violating federal government requirements that mean that all of our programs have to maintain actuarial soundness. So I wanted just to mention that as well. The benefits of an integrated model that we have today is because the CMOs are really charged with coordinating care across a patient. That's mental health, behavioral health, dental health, other medical needs, and look at the patient holistically. DCH is even taking that a step further with the new movement towards a new managed care program going forward. they talk about a person-centered approach, and that is really taking someone's global health status and managing every aspect of it. Now, managing care requires lines of accountability. If we have a dental vendor that is not accountable to a CMO vendor who is handling all other aspects of a member's care, there's no real way to impact or improve performance of that dental vendor. So it takes a lot of the ability of the managed care companies to achieve, I think, what is a common objective here is improving outcomes. The state, as well as a number of other states, are also moving towards a pay-for-outcomes-based approach, rather than the old pay-for delivery of services in a fee-for-service system. And you're looking at ways that you can align incentives and even penalties for failure to meet targeted outcomes by your CMOs and then, by extension, any providers that they contract with. One of the key elements of that is value-based purchasing, and I know that's not an unfamiliar term with members of the committee, but what it is really pay for performance taken to the next level. It combines the ability to withhold payments for failure to meet certain benchmarks with the ability to achieve an actual increase in your reimbursement and incentive payment if you meet or exceed those expected benchmarks. Now, those can flow down to providers to help the managed care company, again, really focus on coordinating care and improving outcomes. Like I said, this is not a payment delivery reform that's isolated to Georgia. I think you're seeing it across a number of other states. One of the other things, too, that I wanted to mention is there is some language in the bill related to contracting with willing dental providers. And the way that I read this is it would require a single vendor, if that were to be the case, to contract with any dentist that comes to the table and says, we'll accept the terms of your agreement. And that really takes a lot of the ability of a managed care company to hold providers accountable for outcomes and to ensure that at the end of the day, members are being seen by very high-quality providers. We're tracked and held accountable through HEDIS metrics to that respect, and I think the ability for any vendor, whether it's a single vendor or integrated in a model like this, is extremely important to make sure that we have really high-quality providers that are serving the Medicaid beneficiaries of this state. That's really the core of the issues that I wanted to raise today, but I'd be happy to answer any questions that you may have.
Okay, Representative Rogers.
Thank you, Madam Chair. Blake, good to see you again.
See you.
Why don't you tell the committee how long you worked for DCH and what your job was, and when did you leave DCH? I wasn't familiar when you left, but tell them, as you told me, you've just been hired by the CMOs, what, in the last 30 days?
It's been about five or maybe 6 weeks ago now. Thank you for the question. I served as Deputy Commissioner of DCH for just about 2 years. I left in July of 2013 and transitioned to the Office of Planning and Budget, where I served as the Healthcare Reform Administrator. So I was handling all aspects of the Affordable Care Act for the state.
Okay. Representative Henson, short and sweet.
Thank you. That's not it. With regard to charging dentists for penalties, I'm not quite sure how you're going to go about doing it. If a kid comes back with more cavities because mama let him eat lots of candy in the 6 months between visits or does not keep his follow-up appointments, will the dentist be penalized? I'm sorry, you really scare me when you begin at applying that,
Sure.
especially to children. Secondly, with the any willing provider, I have a serious problem because when my ex-husband changed his title from an LLC to a PC or something like that, he was kicked out of one of these CMOs for dental because they didn't need more providers in his area. The fact that he had been providing services for a Medicaid population since 1973 had nothing to do with it. He was a willing provider, as were the other doctors in his office. And it was over 3 years before he was able to get back. So any willing provider has many different ways of looking at it, and you portray it in a negative aspect where it isn't necessarily an aspect. It can be very positive.
Sure.
And I really take fault with how you portrayed that.
Well, I'm sorry. I didn't intend to convey that kind of message. And I certainly don't mean to put any willing provider in a negative context. What I'm trying to convey here is that by providing well-coordinated care is dependent upon high-quality providers. The success
Yes.
of my clients depends on the success of their contracted vendors. So that's all I was trying to say in that respect.
I will agree with that. You want high quality, but if someone comes in with all the credentials and everything else, since he might be a new provider in the state of Georgia, what are you going to base it on? He just came out of dental school. What are you going to base it on beside his location if he passes every qualification? So, we use that term very loosely.
I understand. And that's certainly something that, the department would be involved in setting those standards, and be happy to look into that issue further with you if you'd like.
I mean, Blake, I think you're getting some of the frustration of members. I mean, we deal with this all the time, not just on dental, but like having one of the CMOs count in their number of providers that they had. There was one dentist that went to 6 different places, and he was counted as 6 different providers. And so that sent their number up, and yet, so it's that kind of thing that we hear, that we deal with when people tell us they can't get to somebody, and there is somebody that everybody in the community thinks is a good provider.
Sure.
And that person is not able to take them. So I think you're hearing a lot of frustration. Representative Beverly.
I'll wait.
Okay, you're waiting. Thank you. Representative Hawkins.
Thank you, Madam Chairman. Blake, I promise I'm not going to tell your daddy and your sister what you were saying here today. But I do appreciate your candor, and I have a lot of respect for.
Are they dentists?
One's a dentist and one's a surgeon.
Okay.
The daddy and I went to school together,
Okay.
and great surgeon. But I just want you to help me understand something, and I know I heard what you said, but I don't grasp it. You're saying that you want to have quality providers, which we all want that for all types of health care. But wouldn't it be easier to ensure that if you only had one administrator than this maze of what we've got now with 3 CMOs, 3 administrators, and the dentist are sending, their records in or treatment schedules or applying to do a procedure on a patient? I can tell you that gets really confusing in a dental office. I mean, it's like throw it out there and see what sticks. Wouldn't it be better for the patient if we just had one?
I certainly hear you, Dr. Hawkins. I appreciate the question. I think coordinating the care of a patient in the whole, I think, is extremely important. And having those direct financial lines of accountability with a contractor, with a subcontractor, means that we can ensure that expectations are being met under the terms of a contract. Now, I've heard you on the administrative aspects of all this. That's certainly nothing new to this committee or to me. There have been a number of things that have taken place working with the CMOs and the department to make things easier on the provider community. We're very aware of that and want to move that forward. First would be a prior authorization portal. Used to be that depending on which plan a member would be a participant in, you'd have to go to a different online portal and request your prior authorization. That's now been consolidated into one. And that it sounds like a simple thing to do, but from a technological and from a policy perspective, that's actually a pretty heavy lift.
Does it work now all the time?
My understanding is it does. Don't have any indication of issues with it.
I'm sorry, go ahead.
Additionally, the department is also working with the CMOs to move towards a single credentialing verification organization. And that's the onboarding process that Representative Henson was speaking to, so that instead of the old version where you would have to go and get a provider number with fee-for-service Medicaid and then go to each of the CMOs, there's now one place where you can go and all of the information that's necessary will be dispatched to the required parties to take that process forward. So those are 2 areas, just to mention 2, but 2 areas where I think we've made some progress in making things easier, and we're always ready, willing, and able to work with you on others that
All
come
right.
up.
Well, it sounds like the next step is to having one provider since you've consolidated everything else. I want to tell you, you're doing a good job. I hope your CEOs, or CMOs rather, appreciate you making a very valiant stab at this issue.
Thank you, sir.
You're welcome.
Representative Petrie.
Yes, Blake, one quick question. We got some numbers earlier. You heard the Georgia Dental Association mention what really was a 50% decline in providers over 14 years, if I heard right, from 1,585 to 752 providers today. Can you validate that? Do you refute that, or does that sound pretty accurate?
I don't have that long-term historical perspective because when that data was originally done, I was probably in high school, to be totally honest with you. But I'll be glad to look into it. No insult, Madam Chair. But what I will say is we are held to contractual requirements for geo-access, and we are meeting and exceeding those geo-access requirements that are established by the department at this time.
Thank you. I will tell you as you start to work with them, Blake, if you're going to be worried about the whole child and the whole health of an individual, Grady's #1 trip to the emergency room used to be not for gunshot wounds or car wrecks. It was for toothaches. And if you've got a child with a mouth full of abscess or a tooth hurting, they can't study, they can't eat, they can't learn. It's presenting, their overall health is going to be greatly impaired. So I think the CMOs need to get it together. And with that, I'll, and move a little faster in making some of the changes.
Thank you, Madam Chair.
Yeah, okay, that's she waves. Okay, what is the will of the committee? Okay, all right. Okay, we have a move to pass on House Bill 537. Is there any further discussion from committee members? Seeing no discussion, everyone in favor of the passage of House Bill 537, say aye. Aye. Anyone opposed? No. The ayes have it. So thank you very much, Cindy. Okay, have we got a senator that's joined us? Senator Burke. Where? Oh, right there. Okay, Senator Burke, and he's bringing Senate Bill 51. Need to removing this along because if you'll remember when I presented the bill before the committee, we had people testify that we were moving too fast, that there weren't any biosimilars out there, and we didn't need this bill. Well, guess what? Over the weekend, the first biosimilar was approved by the FDA and is now in the market. So, Senator Burke.
Thank you, Madam Chair and members of the committee. You stole my thunder, but because you are the chair, I'll forgive you. I do bring Senate Bill 51 and make sure we're all on the same page. We're working off of LC 371979S. This is a committee substitute that is identical to House Bill 195 as passed through the House by an extremely large majority. It does develop a framework for the ability to, for the state of Georgia to provide interchangeable biologic drugs to our citizens. And because y'all have studied this bill and it's gone through your chamber, I will be glad to answer any questions, but won't belabor the point. I know y'all have a long afternoon. Mm-hmm. Thank you.
Okay. All right, any questions from the committee? It's the exact bill that we passed out. Okay. Okay. I don't see any questions from the committee. Is there anybody in the audience that wants to speak on the bill? No? Okay, good. All right, everyone in the favor of the passage of the substitute to House Senate Bill 51, say aye. Aye. Anyone opposed, no. The ayes have it.
Thank you.
Would I be carrying that for you in the House, Senator, or do you have somebody else?
Yes, ma'am.
Okay. But you do have to go to rules, remember?
I do.
See ya
I do.
at rules. Okay, thank you
y'all.
very much. Okay. House Bill 509, Representative Petrie. Okay. Okay, go ahead. You're a freshman. I think you need to go to the podium. And besides, we want to look at that pretty green jacket. I know.
Oh, he won the Masters.
Oh, I thought we won the Masters. I didn't say sit. I didn't say sit. Yeah.
See the hazing you get in here?
I am feeling better.
All right, this is going to be short and sweet. You ready, Madam Chair? Ready?
You want to run the committee?
I just want to make sure. All
No,
right.
I'm ready. Go ahead.
All right, this bill is very simple. If there is such thing as a simple bill. This is all about palliative care. I was asked to carry this bill by the American Cancer Society as a provider of long-term care and somebody who deals with people with chronic debilitating illnesses and people at life's end pretty routinely. I found interest in it, and what it very simply does is create an advisory body, the Georgia Palliative Care and Quality of Life Advisory Council. And so what's happened in the world I live in is that we've really seen through the years an evolution of how we treat people when they have chronic disease and at life's end. And we've seen an increasing emphasis on quality of life as opposed to just quantity of life. And you're seeing an increasing movement to more person-centered and family-centered care at life's end. So what this bill does is very simply establish a body of 10 to 12 individuals appointed by the Commissioner of Community Health. They have no authority. They will be experts in the field of palliative care. And by the way, I should have mentioned just, I guess y'all have all read this, but palliative care means those interventions that are intended to alleviate suffering and to achieve relief from reduction or elimination of pain and other physical, emotional, social, and spiritual symptoms. So there's so many issues we deal with individuals at life's end or when they're dealing with chronic debilitating disease that where they have no chance of improvement. And oftentimes it's simple things that are social in nature. They might be legal in nature. They might be spiritual in nature, but families struggle. And so this advisory body would be people that are experts in the field of palliative care, and they would be appointed by the commissioner. There's no reimbursement for doing this. It is a voluntary body, and they would advise the commissioner on ways we can continue to move forward. We're a very aging society, and as such, we continue to deal more and more with issues of this nature.
Questions
That's probably simple
for
enough, Madam Chair.
the representative? Representative Kidd. Representative Kidd?
Yes, ma'am, excuse me. Why do we need this as a law? Can't the commissioner go ahead and do this on his own?
Well, you know, I can't argue with you there, to be honest with you. I would say that oftentimes they simply don't. The commissioner hasn't done it. This would require him to appoint a body. He would make the appointments, and hopefully they would have his ear. That's all it does. But absolutely he could do so without a bill. That is correct.
One last question for me. This doesn't even, you know, I've got no objection to it because I might fall under the definition of palliative care. But it doesn't even say that they will make recommendations directly to the commissioner. It just says there'll be this group out there doing their thing, but it doesn't say what they do with the results.
Well, sir, I think my understanding is they will, you know, they make recommendations to the commissioner. And but there's nothing in here that suggests he has to follow those recommendations, which I would not support myself.
Okay.
So,
Thank you.
yes, sir.
Representative Reinders.
Thank you, Madam Chair, and congratulations on getting all the people neighboring you to be your co-sponsor on this health bill.
That's right. You notice that.
Yeah. Let's just talk a little bit about how long they'll serve. How do they
Yes.
come off and on?
Okay?
How do we know you don't come back later and say it's an unfunded mandate and therefore we got to have a per diem for it?
Yeah.
I'm really like Representative Kidd trying to find the need on why the commissioner can't just go out and do this on their own and create smaller government, not bigger government. So
Well, I certainly don't support bigger government, as you know, and so my intention is not to do that. Here's what I would say to that. My intention is to get us focused on issues that I believe are important and to have the department do so. But I can't argue with your point. The commissioner can choose to do so without a bill of this nature. That is correct.
how many members, how long are the appointments?
10 to 12 members at the commissioner's discretion. He would make those appointments. They serve for a period of 3 years, this says, and they receive no compensation.
Representative Pruitt.
Thank you, Madam Chair. When you say no compensation, you mean no gas for going to meetings? No.
Actually, no compensation. This does say, if you go on the third page, it does speak to, but shall be allowed actual and necessary expenses.
Yeah.
So that would be, my understanding from legislative council, that would be gasoline to make trips to meet in Atlanta. Correct, Betsy? Yeah.
Representative Petrie, you need a little help.
I'll take every bit of help I can get, Madam Chair.
Is the reason that they're asking for this council is that sometimes the fact that when we pass a law and put into law a council, it carries a weight of importance. So to send a message out across the state and to us as state legislators that this is an important issue, maybe a new issue that people haven't really looked at, that they're in hospice across our state, there are certainly varying degrees of the quality of care and certainly a great deal of difference in how we're handling people in the last stages of their life, and that if people who really know about this issue could come together and just come up with some sort of guidelines and goals to work for, it might be beneficial for our aging state and for people who have entered this part of their life.
Madam Chair, I agree with that. I will tell you, as a private sector person, I believe that a lot of times, I have to just be very honest with you, the bureaucracies do not necessarily see everything from the bottom up. And my interest, what gained my interest was just the ability to get people to come together and to make sure that that voice is heard in this area, which I believe is going to continue to be more and more important. So yes, I understand. I agree with you wholeheartedly, and that was my intent, just to make sure that this becomes prominent by listening to people that actually work and live in this field, so that it doesn't, it's prominent and at the fore. That was my only intention.
Okay, we'll tell the committee, as much as I hate to admit it, the disparity in the kind of care people are receiving in hospice facilities across our state is so great. And some of the care that people are being given in this very crucial time of their life is so poor that I almost would like us to see us put hospice under CON. I really hate to admit that, but it is really a problem in this state, and there's no regulation, and mom and pop hospice units are popping up, and people are really not getting the kind of care that they should be receiving in this last part of their life. So, Representative Kaiser.
Thank you, Madam Chairwoman. I think my questions may have been asked. I just, again, wanted to know how you came up with the number of 10 to 12, but then I don't want to beat up on you anymore.
No, you're not. Well, y'all aren't beating up on me anyway. I'm fine. But it just seemed to be manageable. I think you get committees that are much larger than that, they can be unmanageable.
But,
unless you're Madam Chair, who has the ability to
Not always.
manage 38.
Could I follow up, Madam Chair?
Certainly.
Since you don't feel beaten up, I'm going to ask my second question. What would those 10 to 12 people, I mean, are there, what are the aspects of palliative care that would like, could you identify 10 to 12 people? That feels like a large group to me. So, you know, could you talk about like maybe the 10 different areas of expertise that would need to be represented on the?
This speaks to that. It speaks to some specifics, and if you'll let me find it here one moment.
Okay. I looked for that as well. So.
It speaks to, I mean, just a plethora of areas, but you've got, it speaks to interdisciplinary palliative care, medical, nursing, social work, pharmacy, spiritual, and it goes on to actually require, it says board-certified hospice and palliative medicine physicians, at least 2 of them. So there are specifics, but there's a broad range of people that are involved in hospice, you name it. But everybody kind of in this world would be an option for the commissioner to choose to get a group of people together that are just having this dialogue. And that, again, was my interest.
Thank
When
you.
I was asked about it, my interest was seeing that the dialogue happens in the bureaucracy, that, yes, we could just say, why didn't it happen with the commissioner? But I don't know that it is. And so I felt like it's valuable because I think it's increasingly valuable to people. And certainly in my industry, what I see every day is people struggling as a family with things they never thought about before. And they're just trying to cope. And my interest was, as I've said now several times, I don't need to keep repeating it, but that we be addressing those issues today so that we're at the fore, really.
Thank you.
So, thank you.
If that isn't what it is. Okay. Representative Chokas.
Thank you, Madam Chair. Two concerns that I have is when the commissioner picks, and I appreciate palliative care and how important it is at the end stages of life and all the aspects of that. It seems, though, that we would need to address that from an educational standpoint. And Madam Chair, I was just wondering if is that some type of specialty in any of the medical fields that we teach?
Well, and we have a second-year resident with us, Dr. Baker.
Very good.
You do, but as you know, we have a physician, I mean, I'm not taking sides on this, but we have a physician shortage and not enough. Pardon?
The continuing education aspect of the Board of Medical Examiners.
As an option for them to,
Yes,
sure,
ma'am.
as an option.
That's good.
Representative Clark.
And I've got,
Oh.
could I have a follow-up?
Sure, sorry, Representative Kidd.
The other thing is, would you entertain putting a limit on any expenses or any cost involved if?
Absolutely.
Okay. Thank
I'd
you.
be more than happy. I actually expected this to be completely cost neutral. And so, but currently, this language, no compensation, but it does have an allowance for travel, et cetera. I would be perfectly fine to see that removed.
Some type of limit, I think, would be appropriate.
Okay, Representative Clark.
Representative, you've worked so hard on this bill, and it has so many good aspects to it. There are a few things that we'd like to see included. I wonder if we could table it at this time just to work on those few suggestions that our members had and bring it back. And
It
so I
sounds like
move,
that would be a good
I
idea.
move that we table it this time.
Okay, we have a motion and a second that we table. Any discussion? Seeing, wait a minute, I got some flashing lights. Are they over? They're finished?
Good with that.
Okay, no questions? No. Oh, I'm sorry.
I had a
Go ahead.
question before the table.
Oh, go ahead.
Or just a statement, quite frankly. I go back a long way in this Medicaid program and the medical program. And at one time, one of our governors appointed advisory committees of physicians, dentists, pharmacists. I think this type of thing solves a lot of problems because so many times the people that are writing these programs and employing the CON I mean the care organizations, CMOs, and don't really know what it's like on the front lines. And I think this type of information given to those people who are making those decisions on contracts is a great advantage. At the time we did it, it did a lot of good for the program, and I think for the people that are making the contracts. But just think it's a good idea. And
Yeah,
however
thank you, Buddy.
this committee wants to deal with it.
And if I could say one last thing, Madam Chair, to Buddy's comment, that is true. In my industry, we used to have advisory bodies too. All of those were cut out under previous administration. And I think you lose something. I think it's good to have people that actually have citizens, and even, you know, individuals who are suffering. As this, you got to have the people that are at the bottom, and people that are providers, and you need input from those folks, or everything's handled here out of the Peachtree building, and that's not necessarily a good thing. So that's really the intent. But I think it's a good idea with all the questions that we focus on this and work on it.
Okay. We have a motion to table it and a second, and no other discussion. Everyone in favor of tabling the motion say aye.
Aye.
Anyone opposed? No. Okay, the ayes have it. We'll expect to see you back over a period of time and with a much improved bill. Thank you. Okay, Representative Jaspers.
Thank you, Madam
Okay.
Chairman.
That's House Bill 564.
564.
The substitute.
It's a sub in your packets there. It's the LC 6130S. As we look for it. You know, as we get started, Madam Chairman knows about this, and she and I have talked many times about prescription drug abuse, and it's a growing public health concern. Because with the increasing number of painkillers and other medically necessary products on the market, the likelihood of a person, particularly youth or seniors, to accidentally overdose or abuse products has really been rising. You know, many states are looking at different methods to reduce this prescription drug use, overdose and misuse by overprescribing, and then enacted different types of legislation to address this. And we hope House Bill 564 is just a step in that direction. You know, currently in Georgia, for physicians, their license cycles every 2 years, and then it expires on the last day of their birth month. They have to complete 40 hours of training, whether it's CME or that's continuing medical education. And what this bill does, if you look down on line 11, it just simply adds 5 hours of continuing education specifically for the use of controlled substances and the risk and indicators regarding the development of addiction to controlled substances. Madam Chairman and I have talked about it a number of times, and we feel that this is one of those steps that would very kind of get the information out to everyone, not just selected ones. If you look down through there, this counts toward their biennial education requirement, and also for the folks in pain management. The only one it did not require on the line 22 was these retired physicians. They have 10 hours of CME, and this would add 5 hours to that. So it's a pretty easy bill, you know, we think, but it's one of those things that should address this in a broad nature and make a good stab at reducing this abuse that's out there right now. Thank you, Madam Chairman.
Okay, we have questions for the representative. Representative Kidd.
Yes, ma'am, Madam Chairman. Thank you to the author. I'm glad you're out of your slang because I was tired looking at all those pins on it.
Well, I took a Tylenol just a few minutes ago. Representative, I appreciate it.
Be glad it wasn't any stronger. I'm very much in support of this. As a person who was legally prescribed medication 15 years ago because it was a new medication on the block for pain, over the course of 15 years, or 14 and a half years, I should say now, that legal medication that I was given turned me into an addict. It was very strong, stronger than cocaine, stronger than heroin. If you ate it, it would kill you. It was just a patch. I didn't even have to swallow it, just put a patch on. Because it was a new pain medicine, physicians prescribed it for a lot of patients. I even went to Shepherd, who initially prescribed it. Then obviously the local doctors say, well, Shepherd is the the guru for pain management with spinal stuff, so they just continue to write the legal prescription. 6 months ago, I decided to get off. And this is, bear with me for just a minute in saying this. But 6 months ago, I decided to get off, and I admitted myself into a rehab facility to get off. And after I got off, I went back to Shepherd, and I met with Alana Shepherd. I met with the medical director, who was the person who wrote the initial prescription for me, and I met with the executive director. And I urged them to stop making addicts out of their patients, because I've seen a dozen or so patients that were turned into addicts because of legal prescription medication. And like I said, what they gave me was new at the time. They didn't know that it was addictive as it is. And I think with a proper education as time goes by, even when additional new medication comes out, over the course of getting the hours of training, they will understand how addictive some of it is and stop prescribing it or prescribe it in a better fashion. And so with that, Madam Chairman, at the proper time.
Okay. At the proper time, we'll let Representative Henson.
Thank you, Madam Chair, and thanks to the author. My question is with the 5 hours. You've doubled the number of continuing ed credits for retired physicians. And you also are not including this in the 40 hours, and I want to know why it's not considered within the 40 hours that the physicians have to already take. I mean, why can't it be? Why does it have to be in addition to?
Well, I believe Representative Henson on the 40 hours on the currently one, that it will be included in that 40 hours. It's not it wouldn't be 45 hours. And like you said, on the retired one, it does add 5 hours. Yes, ma'am.
Our law currently says that we can require up to 20 hours on the retired physicians. And one of the reasons it's the retired physicians that are still working and giving free time. And Representative Jespers and I talked it over, and we decided that if you're retired, you still need to stay up with your specialty of medicine, and that they needed those 10 hours. But they're also out there prescribing narcotics. And so we wanted to add that extra 5. But it's still 5 under what the law currently says can be required of them.
Follow up, please. There are physicians who are retired who just like to keep their license up and are not prescribing and are not working, and you've just added additional 5 hours.
So, Betsy, these are the ones that are working?
Yeah, it's only going to apply to a retired physician if they're doing uncompensated care like at a clinic or something. So they can
So they're still working. Right. So they're, oh, okay. Huh? What? Okay. Okay. All right. Okay. All right. Representative, does he want to?
It seems to me that we're applying this to physicians, but yet we're allowing other professions. We're hearing one today, PAs, of experienced nurses, to be able to prescribe these pain control drugs. Why are you not asking them to have the CE?
Well, we're looking at it, and then we're doing one thing at a time.
Oh, okay.
Yeah, I think also those PAs work under, as you well know, the direction of a physician.
Yeah,
yes, sir.
Reverend, I'll tell you what started this. I attended the academy that they have for the medical association back in the summer. There were about 200 physicians there, and I didn't go to the black tie dinner, and I ended up in the restaurant down at Callaway Gardens, and there were a couple of orthopedic surgeons there, young ones, and they asked me to sit at their table, and so I did, and then one of the lobbyists came in, and then some more people came in, and we were all sitting around, and we got talking about addiction, and the 2 young orthopedic physicians said to me, well, if you have pain, you can't become addicted. And I went, excuse me? Yeah, that's sort of how it starts. You have pain, and you get narcotics for it, and you go on, and they kept saying, no, you can't, to the point that the lobbyist was kicking me under the table to shut up. And because we were getting pretty heated in the discussion. since
I'd like to know who that gutsy lobbyist is.
they're in the room. So anyway, that's what they used to teach. That's what I was taught in nursing school in the dark ages, is that if you had pain, that as long as people had pain, they couldn't get addicted. That is the old way of looking at it. And that's what really started this discussion about the fact that we really needed to be more specific and making sure that people who were responsible for writing these prescriptions were updated on the process. And this is the reason for this bill.
They didn't go to the first class, I think that.
Yeah, they're both fine young physicians. They just a little misled on that issue. So anyway, they both changed their tunes, I can tell you. So anyway, all right. Any further questions?
I just have just a question. I'd love to hear if someone from MAG is in here. I'd like to hear what they have their thoughts on this.
Good afternoon, Madam Chair, members of the committee. In the spirit of humor, my name is Travis Lindley.
That was good.
Yes, seriously, I'm Marcus Downs with the Medical Association of Georgia. We've had an opportunity to talk with Representative Jaspers about this briefly, and we think that it's very responsible. We do have a couple of questions, but I think it's something that we can definitely work through. There is a serious problem with Schedule II prescriptions, and we see, quite frankly, that many physicians don't want to write them and are very reluctant to do so. And so, as we converse with Representative Jaspers and Madam Chair, we'll keep that in mind and at the forefront of any discussions that we have, that our physicians are trying to be very careful and deliberate about how they write those scripts. And with that said, we again think that the idea is a very responsible idea, but we just need to really work through the nuances regarding the actual 5 hours versus maybe something different. Whether or not all specialties will be required to participate in this type of CME. But those are some of the initial questions that we have.
And I think that's something that Representative Jaspers and I agreed to with you. And one of the reasons that and I will tell the committee that it's not just Schedule IIs, which is where we're having the extreme hydrocodone being one of the worst ones. It's a national epidemic. It's all controlled substances, and after talking to the psychiatrist in other specialties, they said if we opened it up to all, then it would fit more of the different kinds of medical doctors, that they could go in and the psychiatrist could look at the addictive medications under all the schedules that related to their specialty and so forth. So that's why we wrote it the way we did, but I think Representative Jaspers told me he's willing to look at it if it goes forward.
All right.
And working with MAG on that.
All right. Thank you.
Okay. Representative Kaiser.
Actually, I had a question for Marcus Downs, but I'll just ask the general question. Since we're late in the day and it's the spirit of humor, don't throw me out of the committee. Okay. I'm wondering if this bill, House Bill 564, doesn't help physicians in House Bill 349 better delegate to their PAs.
Well,
doesn't need a reply.
Yeah. So, anyway, all right. Okay, that's all the questions. Anybody else from the audience? Okay. What is the pleasure of the committee? Got a motion to do pass. Do I hear a second? Got a second. Any further discussion? Everyone in favor of the passage of the substitute to House Bill 564, say aye.
Aye.
Anyone opposed? No? Well, the ayes have it. Thank you very much.
Yes, ma'am.
Okay, last but not least, House Bill 349. And I thank the committee for staying with me. We do have some people that want to present, to speak on the bill.
Well, thank you, Madam Chairman and members of the committee. I know it's late. I will definitely try to get to the point of the reason why I'm bringing House Bill 349. Back in October of 2014, by the way, I'm a practicing physician assistant of 14 years. Most of that experience has been in emergency medicine, so I'm very aware of diversion, abuse. I know all the tactics. They've been used on me as a prescriber to try to extort narcotics. So I'm very aware of that, and I teach students what red flags to look for when I precept them. And so I'd be glad to sit down one day and write my own CME course on that issue. But moving forward on House Bill 349, essentially, when the DEA moved hydrocodone from Schedule 3 into Schedule 2 back in October, physician assistants in Georgia already had the authority to prescribe that medication in particular. When that schedule moved into, or that medication moved into Schedule 2, we were actually, a tool was taken out of our toolbox that helped patients, especially in the rural parts of the state. A tool was taken out of our toolbox to help those people that really needed pain medication. And unfortunately, with this policy, it's sort of, and I understand the need to try to control that, but with this policy, it's become a broad sweeping stroke, and you're actually clipping people who actually really need pain control, especially in the rural areas. I'll give you an example. Recently, I work at an urgent care on the weekends in a rural area. I had a 70-year-old female who fell down. She ended up, it was a 4-day complaint of back pain, and she ended up having what we call an anterior wedge compression fracture, which is a stable fracture of the vertebra. It doesn't cause any problems with pain into the spine or a compression of the nerve. It's a stable fracture, but it's painful. And she came to an urgent care that I was working at, and she had an allergy to codeine, Tylenol number 3, and she was taking what we call SSRIs like Zoloft and Prozac. And the only option that I could give her to consider was tramadol, or also known as Ultram. There is a risk for what we call serotonin syndrome. She was also taking the SSRI Zoloft. And so I am very sensitive to prescribing medication to the elderly that could potentially cause mood disturbances, and especially when they're on lots of medication. So I did not have an option for her. And so the only thing that I could do as a practicing physician assistant, that now a tool had been taken out of my toolbox, is essentially tell her, you need to go to the ER now if you want adequate pain control. The doctor could prescribe that for you. But what that did was she waited 4 days to be seen, and she finally got saw. I diagnosed that by X-ray. She decided to go to the emergency department because she was very uncomfortable to get a prescription. So she is a Medicare patient. So what that did was it cost the taxpayer another round of an assessment that, in my opinion, was unnecessary. And we find that over and over in different renditions of stories in rural Georgia. So she went to the ER, checked in, got her pain medication that she needed to tide her over until she got in to see her physician, because it was on a weekend. So we have a problem. It is an issue, and because of the DEA's change in Schedule 2 that moved in hydrocodone into Schedule 2, we're somewhat inhibited in the rural parts of the state. And I've got some talking points in your packet there. And on the second page, I want you to take a look at these statistics that I think is...
I don't think they made it into the packet. They didn't get my approval for it, and I was on the floor.
Okay. Well, what I will tell you then is these statistics came from the Georgia Drugs and Narcotics Agency. Okay. So what I did is I actually looked at the time in which before PAs were actually able to prescribe from October 2013 to January 2014, and I took that same time period and I compared it to October 2014 to 2015, and that was the time that the DEA moved that into to Schedule 2. And what you found was pretty interesting statistics. The number of hydrocodone pills dispensed actually did go down from 84 million to 68 million pills dispensed. That's 16 million pills. The number of hydrocodone prescriptions filled did also go down, and that was a reduction of about 340,000 prescriptions. And the number of oxycodone, which is a stronger medication in Schedule 2, that actually increased of about 500,000 pills. And that's interesting because physician assistants do not have Schedule II prescribing privileges in the state of Georgia during that time period. So I found that rather interesting when that number was actually went up. The number of oxycodone prescriptions had also increased to about 18,000 during that time period. Again, physician assistants are not allowed to prescribe Schedule II in the state of Georgia during that time frame. Also, what's interesting is that Tylenol number 3, which is a Schedule III medication, that actually went up to about 400,000 during that time. So I can infer that physician assistants are now resorting to Tylenol number 3 to try to treat fractures or kidney stones, and many times that is a very inferior drug to treat those kinds of conditions. So that's really what I have here. I do have a couple of people here to speak to the bill. I do have some letters from the Georgia Rural Healthcare Association and the Georgia College of Emergency Physicians actually supporting some form, limited form, or some other form of Schedule II authority for physician assistants. One other thing, I do want to sort of walk through the bill just quickly before I
wondered
take
if
any
you want to get to
questions.
that, Representative Spencer.
Well, here you go. If you look at the first page, that's where, right now, current law is 2 through 5. We add in that the Schedule II controlled substance on line 15 is in accordance with subparagraph B of this paragraph. And basically what I put in there is that a physician already delegates that authority to a physician assistant anyway. That's current law. That's the principle of the PA Practice Act, is that the physician is the one in charge and that the physician gets to decide what the PA gets to do. And so in that, I decided to put language in there that would allow the Schedule II to actually be prescribed within that physician's scope of practice, and also allow the medical board to even define any rules or regulations governing that prescriptive authority within that physician's scope of practice. And I've also added in a CME requirement, much what was discussed earlier. Physician assistants know that we have an issue out there. I face it every day in the trenches, and we are not opposed to CME requirements. We have to have 100 CME requirements every 2 years. That's 50 Category 1 hours and 50 Category 2 hours. So we have to constantly maintain our CME up to date. We have to retake our boards every 6 years to get recertified to keep our license active. So if there are any questions, I'll be glad to yield any.
Okay, Representative Hawkins.
So help me understand this. This bill, you're asking to write any Schedule II. Is that correct?
Within the physician's scope of practice.
Right. And isn't there a Senate Bill 115 that just adds hydrocodone compounds, 2, 3s, 4s, and 5s that you can write right now?
Right. They actually had a more comprehensive bill, and they sort of spelt out different requirements for different, like palliative care, orthopedics, emergency medicine. They sort of enumerated all those in there. I just simply took a different approach. I said, well, if the physician is already delegating that responsibility to the PA, and they're in oncology or if they're in emergency medicine, then let that scope of practice determine what's prescribed. And if the medical board wants to sort of regulate that within that schedule, then they're more than willing to do so. I think, they're it's made up of physicians, and so they should be able to come up with some reasonable regulations to
Right.
regulate that.
You were talking about teaching students. I'm an adjunct professor at the Medical College, Woods Medical College, Georgia. That's Regents University, and dental students will do rotations through our office. And I actually have dental students who do not even apply for the Schedule II drugs, although they can legally write them, because of some complications that could occur. And I understand that you're under the direction of a physician, but you would be making these decisions without the physician being present. Is that correct?
Sometimes the physician is often not present in rural parts of the state, and
Right.
Usually when the physician hires a PA, there is an agreement between
Office agreement, that's right.
the physician and the
Protocol.
PA about what they can and can't do, and
Right.
that typically develops over time, especially with comfort level, with years of experience.
I have a question for you, but you still are making that decision whether to give that patient a prescription for hydrocodone, or if you would be able to order any of the Schedule IIs that you're proposing, including the new one that's 20 to 30 times more addictive, the new medication that's out there. And refresh my memory, I don't believe that PAs have a right to go into the, what do we call the thing that the doctors go into? Where they see who's prescribing what.
The drug monitoring program?
The PAs do have that?
Yes, they can.
I thought it was limited to the doctors.
No.
Are you sure? I'm going to check it. Okay. All right, stand corrected on that. I'll have to look the law up on that one because I thought it was limited to the physicians. They have a number. How do they get in it, Tom?
I would defer to a practicing physician assistant.
How do you look up something?
I personally do not have access to that information because my particular practice, do very little prescribing of hydrocodone. Only in very extreme cases. I am instructed by my supervising physician, broken bones or kidney stones, and that's it.
But you still, on broken bones or kidney stones, you still have no way, or at this point have no way of looking it up.
I can do that if I need to, but I haven't done that personally because I often don't prescribe those very often in small cases. So, but
Yeah,
Tina might be able to answer that
You have to apply and
question.
be issued a number. Okay. Representative Kaiser.
Thank you, Madam Chairwoman. I just, as a co-sponsor of the bill, I keep feeling like there's a question as if the PA can do this without having direct delegation by a doctor. But that's not the case, correct?
It's indirect supervision. And I'll have Tina Hood here. She's a practicing physician assistant in rural emergency departments across southeast Georgia. She can answer that. She's in that setting where it's relevant to her.
Okay.
I'm a little bit more closely supervised than maybe she is in that setting.
Well,
So
when we spoke about this bill originally, is your concern mostly about rural parts of the state? Because I know that I see a physician who is oftentimes not in the office, and I almost always see the physician's assistants because typically that's not just true of rural areas. In urban areas, there oftentimes the physician is somewhere else, whether it's multiple practices or.
Yeah.
And I typically almost always see the PA for that reason.
I do have colleagues that are in the metro area that also have a problem with the current policy, but I can only personally speak to what's happening in sort of rural Georgia because that's where I'm at. But you're right, that is happening in the metro area.
Okay. Representative Kaiser, I think the question is, and as that some of us have discussed, they do have to have a physician, a protocol with a physician to be able to do it. However, as we discussed in the need for more continuing education for the physicians is we have a major problem, and perhaps the physicians don't see that, so delegate too easily to let people give them. Am I making myself clear on that one?
It is. So then that clarifies what I said about the previous bill being a good bill
Right,
that
but
complements
it
this
doesn't
one.
but it's just the beginning to
Right,
get it to
right.
try to undertake the problem.
Right. I
Maybe
understand
the
that.
whole country has a problem with the need for, including citizens, that we think that every ache has to be cured with a pain pill. I think there's a perception problem across the board in our country about what narcotics can do for us and how safe they are and all.
Right.
That thing. So.
As a co-sponsor of the bill,
Right.
I understand.
So. Okay. Representative Kidd.
Thank you, Madam. Mr. Chair, obviously, I'm very supportive of the PA Act and so forth. I've sponsored legislation for in the past, and I co-sponsored this one and hope that some of the language might be massaged somewhat before we got to this point. Unfortunately, it wasn't. But I'll ask you this question. Do you think today, throughout Georgia, throughout the country, there's a overprescribing, legally an overprescribing of addictive narcotic drugs, opiate drugs?
I personally do believe that.
Nothing against your practice, but do you think, given this blanket authority to additional practitioners, it might possibly exacerbate the problem, make it worse?
No, I don't think that's true, and that's the statistics that I shared with you earlier. The statistics that I shared with you is during the time that the PAs moved, or the DA moved hydrocodone from Schedule 3 to Schedule 2, there was actually an increase in the number of oxycodone prescriptions during that time frame, according to the data monitoring information I got from the Georgia Narcotics Agency. So, but that infers if you look at the increase in the number of oxycodone, that it's not the PAs that are actually prescribing it, that's the physician.
I think we have Mr. Allen here with the head of drugs and narcotics that maybe can clarify that,
Yes, ma'am.
or add to it, or agree with it, or disagree with it.
One or two more brief questions, if I may.
Quickly.
Right now, you know, clarify. Right now, you can you basically set up shop yourself somewhere and have patients walk in off the street to see you, and
No.
they can never see the MD, and you can prescribe medications?
No, that's not how the PA Practice Act works. The physician, I as a physician assistant can't hang up my own shingle and call myself, I'm open for business. I'm what we call a dependent practitioner. We are not independent practitioners, so I can't do that.
Let's go back to the lady you said you saw that had this, serious pain in her back and so forth.
Mhm.
Had your supervising physician ever seen that person?
During that event, no, because I'm the one manning the urgent care clinic at the time.
That's my point. So the medical doctor who has the right to oversee you,
correct,
had never seen that patient or talked to you about that patient, but you're wanting now to be independently to be able to write a controlled substance class 2 drug for that patient with the medical doctor having never seen them.
The physician assistants have been doing that for a while under the current PA Practice Act before the DEA made the change. So that's a practice that we were doing anyway with direct and indirect supervision. We oftentimes in rural areas, in very remote areas, it's the PA that may be manning a small emergency department. They may have an agreement with a larger regional center to consult. So yes, sometimes there are staff physicians on staff at some of these hospitals in rural areas that they can directly ask about supervision during when they're actually seing patients.
Last thing, Madam Chair, and I'm through.
Okay.
Like I said earlier, I support physicians' assistants and have for a long time. But when this particular bill, as it's written right now, Madam Chair, at the proper time, I'd like to move that it be put in a subcommittee to be worked on and brought back possibly at a later date.
Okay. Okay, thank you. We'll on that. Okay, we have some people here that I want to call on to speak. First, Mr. Allen with drugs and narcotics.
Thank you.
Thank you for coming and sitting. I know with your recent surgery, the pews are hard.
Yeah, they are.
So sorry that you've had to sit through this.
That's okay. Good afternoon, Madam Chairman and committee. I appreciate seeing Representative Broderick back from a successful venture downstairs. Thank you. Representative Spencer said pretty much everything. I can help explain some of the statistics, and that's what they are. Okay. I didn't want to make sure the committee, and that might be, I don't know if it's in your packet or not.
Is this right here?
Did it get in there? It's in, yes. Yeah.
Is this it?
No, ma'am. Yeah, Dr. Sperry's got more good stuff.
Oh, can you see? Okay, it's a long piece of paper, everybody.
Yeah, the first one.
It's
Do you
got
realize?
what?
I want the committee to realize what's in a Schedule 2, what it is.
Here it is.
It's it's raw opium. It's cocaine. Yeah, I think the committee has that.
Here we go. Okay.
It's diluted, which, no offense, that's what I want if I have kidney stones. Cocaine, methadone, Demerol, Adderall, go back to Didrex, Desoxyn, Amatal, Seconal, the drugs that are highly addictive that really have some medical use. Up there near the top it says ethylmorphine. That's not really a drug used in this country, but it's used in Europe. And it has to be on the list because it should be a Schedule 1, but it does have medical use. When DEA did with hydrocodone, they struggled over it for several years. They were going to make hydrocodone. Now, what hydrocodone itself has always been Schedule 2. What was in Schedule 3 was combination products, which is basically the hydrocodone. with Tylenol. So Lortab was a hydrocodone with Tylenol, but if the drug Zohydro is pure hydrocodone, it's always been a Schedule 2. Well, DEA had thought about making a hybrid Schedule 3 or 3A or a 2 or 2A to allow call-ins of hydrocodone, to allow refills of hydrocodone. Why they came up with what they did, to me, they ratted out and just moved everything out of Schedule 3 and left it in Schedule 2. So but what it means when you get a Schedule 2 number from them, they're not going to know what the agreement is with a physician and a PA. A physician's assistant here in Atlanta is limited to hydrocodone. He or she could write a prescription for Dilaudid or cocaine, actually, and take it to a pharmacy, sit down in Macon. They wouldn't know, they couldn't fill it because you would have a DEA number that would have a Schedule 2 authority on it. But you can't look up on DEA. DEA does not limit Schedule 2 to certain drugs. You either have one or you don't have one.
So in other words, when you apply for a DEA license, you get the whole shebang or nothing.
Yes, ma'am. So that, I wish it was different, but that's the way they are. The numbers, yes, hydrocodone did go down. It was so far up it didn't have anywhere to go but down. The numbers went up, like he said, with the Tylenol number 3. The Ultram stayed pretty stagnant. The one thing that was interesting, the cough syrups with hydrocodone stayed about the same, even though they went up to Schedule 2. So we're just concerned that you're going to have rural pharmacists somewhere don't have a clue, which there are a bunch of those, that are going to be filling these prescriptions for any Schedule 2. In the past, we've had trouble with physicians' assistants abusing their authority in that sense. So it's sad, but it's a fact of life.
Mr. Allen, why do you think that the DEA moved hydrocodone to a Schedule 2?
Because FDA said it was the most highly abused drug in the country. It was the main drug leading people to heroin abuse. Dr. Speary can speak to a lot of that. But the way DEA and FDA looked at it, they had to do something to try to get the abuse down, and that's why they finally said, okay, we're just moving it to Schedule 2. We're not going to do a hybrid DEA number.
In a desperate attempt to try to limit the number
Yes, ma'am.
prescribed.
That was the purpose, pure and simple.
Questions for Mr. Allen? Okay, go ahead.
Thank you, Mr. Allen. Thanks for being here so late. So like that PA that you described there a moment ago, that's abusing that ability to do that. I was going to ask this to Representative Spencer, but I'm going to ask you, what's the penalty? I mean, what do we do? What happens on your end, or our end, I should say, that it's that catch-all that stopped?
I'm afraid we would arrest them. Representative Johnny Caldwell, who back in the day, come May, I'll be doing this 40 years. Back in the 70s, we had a case when Johnny was Representative Caldwell was the district attorney down in Thomaston. And we had a PA that was stealing signed blank prescriptions from his physician and writing drugs like Quaalude, biphetamine, drugs that aren't around today. Representative Caldwell, as the DA, went to Arthur Bolton, and they passed the law, and Georgia's one of the only states where it's illegal for a physician to pre-sign a blank prescription. And that came out of Representative Caldwell's activities down there and the physician assistant that we had to arrest.
So how does that, if I may, Madam Chair, does that go back to the physician who may be over Representative Spencer, the lady beside him? How does that flow back up to them? I think that's a question this committee grappling with looking at allowing PAs to do this. Is that let's flow back.
It would probably be a medical board issue. I don't know that there would be a criminal unless you put it in there in the code. But if a physician's assistant was abusing their authority, to the best of my ability, the medical board would take action just like they did years ago on the physician.
Would the medical
Yes, sir.
board take action, or I mean, because with the nurse practitioners, the medical board doesn't have the authority to take that. The nursing board does, and unfortunately, the nursing board doesn't take action.
It would
but
take about 3 years to get something done.
get something done.
Yes, ma'am. They would be the RN board on the nurse practitioner.
Okay, but the medical board on the physician's
Correct.
assistant. How would you know, even using our drug up data system? Now, am I correct on this? When you can't go into it without a subpoena, basically,
Search
and
warrant.
pardon,
A search warrant.
search warrant.
Yes,
Okay,
ma'am.
is that worse than a subpoena?
Much worse.
Oh, okay. Oh, really? Okay. But when you go in there, the PAs, am I right, Representative, that the pharmacies, it's not the physician's name on the prescription? So what goes into the database would go under, that would be under the doctor's name. So it would show up on the
Right.
thing.
And the
So-
bill that would hopefully just pass out of the Senate non-civil judiciary is going to fix that, to make sure the PAs and nurse practitioners' name are used on the prescriptions.
Because that has been a problem in the past,
Yes,
hasn't it?
ma'am. We're fixing it. Let's put it that way.
Because in the past, a lot of times it just went under the doctor's name and you wouldn't know
Right.
if it was a PA or a nurse practitioner prescribing it.
Correct.
Okay, but there's a fix in the Senate?
It's already passed the House and that's in the Senate.
In the drug update bill,
Okay.
instead of physician, it says the practitioner.
Okay.
The name that goes on the prescription and the label.
Yeah, theoretically, Dr. Hawkins couldn't even write a prescription and put his name because it said physician name on the label.
So Dr. Hawkins,
Well, theoretically, I'm just.
theoretically.
But yeah, and said a pharmacy, any pharmacy or anybody with a DEA number can go into the DEA website and check a DEA number to see who it belongs to and what authority they have. So if the pharmacist in Macon was checking on a PA from up here, all they would see was Schedule 2. They wouldn't see anything else.
Okay.
Madam Chair, to answer your other question, I know that both the dental board and the medical board have gone in and didn't let a practitioner practice, but they restrict what prescriptions they can write if they've been writing an abuse of a certain type. They can still practice where they're doing, but they can't write prescriptions. I know the dental board and the medical board have done that. I can't speak for nursing.
Okay. Other questions for Mr. Allen? Okay. Thank you, Mr. Allen. I'm sorry you had to wait so late.
That's all right. Thank you.
Okay. Dr. Chris Sperry.
Good evening. It's a pleasure and a privilege to be here. I've been your chief medical examiner for, it'll be 18 years in June, so I've been working for the state for a long time. And I've seen specifically with relationship to drug deaths a very alarming trend that started about 10 years ago. I've given you out a bunch of information, bar graphs of different sorts that really summarizes the deaths that come through our office. Most people, in fact, I know just from the conversations here this evening, I know that almost everyone is aware that there's a tremendous increase in drug-related deaths and prescription drug-related deaths, but very few people outside of my circles and also Mr. Allen's circles really comprehend the numbers that are involved. I would like you to look at, there's one graph that has red and blue bars on it together. This is a summary of the total number of drug-related or drug-caused deaths that have been analyzed and examined by the State Medical Examiner's Office for 2010, 11, 12, and 13. We're still in the process of getting the data for 2014 yet. We don't have that. But for these 4 years, over this 4-year span, there was a total of 2,326 drug deaths in the state of Georgia that came under my office's examination. Of those, 2,053 were related only to prescription drugs. That's 88%. Every year of those 4 years, it has been a steady 88, and 1 year 89%. And that's rather phenomenal because most people think of drug deaths in relationship to cocaine, heroin, things like that. And we also see a pattern as well that in the majority of drug deaths that come through our office that we examine, there's usually about an average around 3 different drugs inside of them that we find. And most commonly it's an opiate, a narcotic, plus Xanax. The chart that really summarizes the totality of the drug deaths is the one that has multiple bars that are all different colors. And of course, I put that, I set that up here. This is it, which is, it looks like a little rainbow.
Ah, it does.
And it shows the total number of deaths over these 4 years in relationship to the top 11 drugs that we find in systems. And the numbers for the deaths for hydrocodone, methadone, and oxycodone are all relatively similar as far as the numbers. And then finally, because we are talking about hydrocodone itself, there is one specific bar graph. We have bar graphs for every one of those 11 drugs. But there's one for hydrocodone alone that shows in 2010 we found 145 deaths where hydrocodone was in the system. In 2011, 133, 2012, 125, and 2013, 125. Basically, 26%, or a quarter, of all of the drug deaths that we analyzed of that 2,053 deaths related to prescription drugs, about 1 out of 4 had hydrocodone in their body. So I've gone on record before in hearings, in interviews, in seminars I've taught in the state related to drug abuse as saying that there is a prescription drug plague in the United States and specifically here in the state of Georgia. And considering that 9 out of every 10 drug deaths that we analyze are prescription drugs only, just for comparison purposes, over these same 4 years time span, we had 64 heroin deaths. That's all, 64, but over 2,000 prescription drug deaths. So I can't do anything more than show you or share with you the actual numbers that we have derived, but I can tell you every single day we have 2 drug overdose deaths a day that come through our office, every single day. And like I said, it is plague.
Are you seeing a pattern of where these are? I was reading somewhere, and it said that most at risk were white males in rural areas.
Exactly. White males between 35 and 55, predominantly in rural parts of the state. Those are the individuals that most often come through our office as prescription drug fatalities.
So, and do your figures include, is my understanding that Cobb County and a couple of the other big counties, they have their own medical examiners and they don't come through you?
Correct. Cobb, DeKalb, and Gwinnett and Fulton have their own medical examiner offices, and so a couple of the counties, I know Fulton, I know Fulton keeps statistics, but the other 3 don't. The overall number, no, they don't. They don't have computerized systems, and we have tried to get that information. I know that the numbers are much smaller only because the quantity of deaths that each offices analyze is much, much smaller as well. And Fulton has a little bit more of illicit drugs, illegal drug problem, but still, when it comes to prescription drugs, the predominance of what we see, because of course we serve Macon, Columbus, Augusta, Savannah, larger metropolitan areas around the state, the predominance of deaths still leans more towards rural, smaller town parts of Georgia.
Okay. Questions for Dr. Sperry? Okay, Dr. Hawkins.
Do you see this as what percent of these deaths are people using the drugs off prescription?
Off prescription, well, the majority, we classify the majority of these as accidental in the sense that they are the quantity of the drug in their bodies is not as high as what we would see, say, in a suicide or intentional ingestion. Usually, it's a problem of a combination, a narcotic plus Xanax,
Right.
oftentimes something else.
Respiration.
Exactly,
Right.
and there is just a little too much. In other words, they've on a given day. Say someone's having more pain than usual, or they become tolerant to a certain amount of drug, and they take maybe 2 or 3 tablets more, and that is enough to make them pass out and stop breathing.
I guess what I'm asking is the percent of the pay or the percent of the deaths that people are using the drugs illegally. In other words, they have not been prescribed the drug. That's where I'm going.
Yeah, I understand. The vast majority are not illegal, and actually, since the advent and the availability of the prescription drug monitoring database, actually, my office looks at the decedents we have come through our office. We go on the database and look to see if these people actually have been prescribed the drugs that we find in their system. The vast majority, and the answer is yes. They are legitimate prescriptions, and we actually, in fact, we get the bottles. That is one of our requirements, is that cases are brought in, that the coroners or law enforcement include all the medication bottles that we find at the scene or are found at the scene, so we can count pills and start looking to see if there's a deficit in certain drugs, certain quantities of medications. But the majority are not illegal uses of the drugs. We do see, though, a lot of multiple prescriptions from different physicians for oxycodone, for other narcotics. So
that's the primary problem then, the cause?
Yes, doctor shopping and duplicate prescriptions for different prescribers.
And combination of drugs?
Yes, sir.
Right. Okay. Thanks.
Representative Henson.
Thank you. 2 things. I thought that we had put some legislation into place with the pharmacies so they could, when they pulled it up, they could see if someone was doctor shopping and filling these prescriptions elsewhere.
That's what we've been talking about.
Yeah.
Your system.
But yet, you're saying that you can see where they're doctor shopping, so I'm wondering why it's not being caught by the pharmacies and stopped.
Well, I think Mr. Allen probably can talk about that more because his division regulates pharmacies, but all I can tell you is what professionals can do and what they will do are two different things. Okay. And I see repeatedly prescriptions for narcotics, for Xanax, from different prescribers, and also quantities that kind of blow my mind at times. A prescription bottle for hydrocodone with 240 pills in it, written at one time, or 180. I kind of don't quite understand that. I'm a physician myself, and I still can't wrap my head around prescribing that quantity of a medication, of a narcotic medication at one time, but yet I see it almost every day.
I have one follow-up question. You keep mentioning Xanax. I mean, all the rest of these are pain pills, and that one I didn't think was a pain pill.
No, it's not. It's an anxiety reducer. Alprazolam is the chemical name that's actually on your handout. Alprazolam has been used and still is used as in other types of drugs as an anxiety reducer in combination with narcotics to help alleviate some of the anxiety and fear, and that goes along with pain. One of the problems, though, that has been discovered is that the mixture of narcotics plus alprazolam has a definitely and a well-known increased toxic effect. And this is extremely well known with methadone, which is a very, very potent pain reliever. That actually a few years ago when OxyContin, which is a time-release formulation of oxycodone, was severely restricted because it was being abused incredibly throughout the country, and especially in the East. When that became very, very difficult to get and insurance carriers stopped paying for OxyContin, physicians switched over to prescribing methadone, which is very powerful, and it's dirt cheap. It's been around since World War II. In fact, the Germans invented it during World War II. And it is very potent when combined with alprazolam or Xanax. But those two are still prescribed together, although the probability of dying is tremendously increased.
Thank you.
Thank you, ma'am.
Other questions for Dr. Sperry? Thank you very much.
Thank you, ma'am. And just let me thank all the representatives for the support I know you're giving towards the medical examiner's office at the GBI this year. I rarely get a chance to speak in front of groups such as yourself and certainly our legislators. And I can tell you, you have my heartfelt professional thanks and that of my staff for the help that you're giving us, because as Georgia has grown, we have grown, and we want to keep on meeting the needs. So thank you very much.
Thank you for the work you do, and tell your staff we appreciate them also.
I will. Thank you.
Okay, Tom Bowers. And we have two
Thank you,
people.
Madam Chairman. I know it's getting late, and I appreciate you folks hanging in here. There are just several points I would like to address, and I'm just going to try to hit them quickly, and with your permission, give you guys some written information. This bill is just for a hearing. I'm sorry, I'm Tom Bauer with the Georgia Association of Physician Assistants. We appreciate Representative Spencer bringing this so you would get a good discussion of this issue. As Representative Hawkins pointed out, there is a bill, Senate Bill 115, that hopefully will be coming over. That is different from this bill. It is a bill that has been negotiated with the Medical Association and with the Medical Board, and they support it.
I don't think that's quite true. I think there's been some talks, but it's not full support from both those groups.
My understanding that...
I talked to the head of the Medical Board he called me yesterday.
Yes, ma'am. Well, based upon an email that I got, my understanding was that they were supporting the hydrocodones, but I'm not. We'll certainly address that as we go along. Let's just want to put a couple of things in perspective. PAs can be delegated prescribing Schedule II medications in 40 of the 50 states. And Alabama recently became one. So we're not talking about a radical idea. And just a few things that I'd like to say, and I will present some more data to you. Mr. Allen mentioned one thing about that the pharmacist doesn't know. The pharmacists, I believe, in most areas know what PAs can prescribe. And also, this bill, the one at least that we will be presenting, hopefully coming over, will be just restoring what a PA was doing before October 7th, with more restrictions, as a matter of fact. Up until that point, they were able to be delegated the hydrocodone combination products. This bill coming over, if it makes over to the Senate, will have a 30-day supply limit. It will require 3 hours of CME.
We'll discuss that bill when it comes over, Mr.
Yes,
Bowers,
ma'am.
if you just
Yes,
limit
ma'am.
it since the time is
Okay.
late.
Okay. One other point I would like to make is you can't really tell who's prescribing the medications, and we do acknowledge that 16 million prescription pills went down. Interestingly, PAs make up 11% of the prescribers in the states. So if you accounted for all those pills from PAs, we would be talking about every PA in the state writing 1,000 prescriptions a month for something like Loratab. We also have some research, and I'm trying to get even more updated, but 4 of the 5 states that were cited for the most prescribing of painkillers by the National Prescription Audit, 4 of those 5 states, PAs could not write Schedule II, and conversely, the 5 least prescribed painkiller states, getting tongue-tied, PAs could write. Just to clarify one thing, Madam Chairman, PAs do participate in the drug monitoring program. Jeff Chambers, who's an orthopedic PA, had a very interesting story which he related to the medical board last summer, where he actually caught somebody drug shopping and provided the information as we went along. Let's see. A point that Senator Kidd, you had asked Representative Spencer, and he was referring to when he sees a patient, usually initially, when you do have a patient that's being prescribed controlled substances by law, now by a PA, the physician has to evaluate every 3 months. So it's not sort of a hands-off, and he certainly cannot hang out a shingle because it's the physician that hangs out the shingle. There was some confusion or some mention of the Xanax, and I just wanted to point out, and this is something that's already happening, and it is in keeping with what Representative Spencer had in his bill as well. But a PA cannot prescribe something that's not within the scope of practice of the physician he's working for, or he or she's working for. So you're not going to have a dermatological PA, for instance, prescribing Xanax, Representative Henson.
Excuse me, Mr. Bowers. There is nothing, if he has the right to write that you can guarantee that he will not write something.
I'm sorry, I didn't follow.
If somebody has a DEA number to write Schedule 2s or has the right to do Schedule 3s, you cannot guarantee that just because he's a dermatological PA that he will not write something in another area.
Well, absolutely, you can't guarantee that. But
that is a false statement. To address Representative Jasper's point about PAs and physicians are disciplined by the medical board, and I do know that Ms. Hughes has told me in the past that they have fewer problems with PAs than anybody. But I'll just throw that out anecdotally. Who has said that?
LaSharn Hughes, the head of the medical board. But I just wanted Representative Jaspers to understand that yes, we are. The PAs are regulated by the medical board, as are physicians. So,
I think Representative.
And one other thing, I'm sorry, and then I'll stop. You had asked Mr. Allen why the DEA rescheduled that, and obviously he got that right, and there's concern about overprescribing. But this is something that PAs have been doing, and if restored, they will now not be able to call it in, but they will be able to write it in, and that's much safer. So thank you for the opportunity. I appreciate y'all sticking around.
But in the basic question, when we get down to it, there's too much prescribing of hydrocodone and OxyContin by everyone, and they are dangerous drugs. Is that not the baseline question that we are looking at here?
I would agree with you that is a problem, Madam
Thank
Chair.
you very much. You have questions. Okay,
Thank you.
Representative Kaiser. Kaiser had one too. I thought you wrote me a note. You had things you want to clarify.
He was going to talk.
Okay. Representative Sharper.
Thank you, Madam Chair. I just have a brief comment. I want to go on record and stand that I've been in the medical field over 25 years, and I've worked with a lot of physicians' assistants, and we got to understand that they're professionals just like everybody else. What I'm hearing now is everybody thinking that if this does pass, that they're just going to say, hey, we can do it, but we got to understand they're professionals. Anybody, doctors, nurses, anybody can do anything they're not supposed to do. Right. But in the rural areas, we need help in those areas. I've worked in about 10 different counties. Physician assistants, they have came and did what they needed to do to help those communities where we can't afford to hire doctors. So therefore, we need to give them what they need in order to take care. It's all about the patients. So I just want to go on record and saying that I fully support this bill. Physician assistants, they're professional ones. There's going to be good and bad in every profession. So, I support this, and I just want to say that.
Representative Sharper, I don't think anybody is trying to degrade any profession. If you have heard us talking about the fact that physicians, are a problem too. The problem is the drug problem that we have in the country, and perhaps finding a way for everybody to use them less, to find other means and so forth. So it's not meant in any way to degrade any profession, but we have a huge drug problem in the state of Georgia.
Right, and part of that drug problem is actually a financial problem because a lot of them get them and sell them. So there's a problem within the problem.
Within the problem. Yeah, there was a little old lady that told one of the orthopedists that refused to give her another prescription when she was well. And she kept insisting on it. I think I used this in another thing, and she finally said, "Sonny, don't you understand? This is the way I supplement my Medicare."
Right.
It happens to everybody. Okay, we have two more people, and
thank you, Madam Chair, members of the committee.
You're welcome. Ms. Hood.
Thank you, Madam Chair, and members of the committee. I'll be very brief. My name is Tina Hood. I'm a PA that works in the rural area. I guess you could say that I represent the rural PAs in the state in a way because I am one of the practitioners that understands and works in that area. I'm also a huge advocate for my patients. That started out years ago as a paramedic and as an RN and now as a PA. In rural areas, we have rural and critical access hospitals, and in those areas, working under the guidelines of the medical board and the state legislature and state laws, we actually have PAs that that work in the emergency room setting. The physician is readily available. He is there within minutes if we need him, but he doesn't come in on every patient. And that is within the guidelines of the medical board and the state laws. There have been patients that I have had that have come in, and it was like, when this started in October, I've had patients that have come in with broken bones, multiple facial bone fractures, kidney stones. Typically those kidney stones that are 5 millimeters and less, you'll have a urologist that'll say, well, just give them something for pain and then have them see me in 3 or 4 days. They'll re-x-ray it and see where the stone is moved. They don't go see the urologist the next day. It's kind of the same thing with people that have fractures, like a broken wrist fracture. If it's not dislocated, if it's not angulated severely, basically I can call the orthopedic guy that night, and he'll say, just splint it, give him something for pain, have him come see me in a couple of days. The lady that I had with multiple facial bone fractures, I spoke with the ear, nose, and throat. They have to go to that specialist, and that was his thing too. And I said, well, as of this time, I can't write her anything any stronger than Tylenol 3 or the tramadol or the Ultram. And still he doesn't see her for at least 3 or 4 days. And it's not that they're operating outside the guidelines or anything. That's, you got to let the swelling go down before you can do any procedures. I did get the letters from the Georgia College of Emergency Physicians to support our legislation as well, and from the Georgia Rural Hospital Association. We have like 61, I think, critical access and rural hospitals, and many of these stay afloat by and also addressing the physician shortage in the state. They stay afloat by the PAs, working in the ER. And basically what we do, I work Lakeland and Quitman, and if I have a patient that has to be transferred, they go to the larger hospital. But there's many times, like with the patients with kidney stones that are less than 5 millimeters, or the broken bones, you don't transfer those. You see them, you treat them, you let them go home, and you let them follow up. I've had patients that will come to the ER, that actually if they went to the larger hospital, it's harder for them to get home, because we're talking about, rural areas where there's, low-income people, and it's a lot easier for them to get somebody to come up there to pick them up. But I've had people go to the larger hospitals and wait. I know when I worked in Tipton, I have worked at some of the larger ERs as well for years. We've had patients that waited there for 8 hours for somebody to come pick them up. So I'm just here trying to get some help for the rural Georgia. I know that from some of the conversations, I kind of felt like the cards were stacked against me, but there's a true need here, and people are suffering, and I just came for my patients, that's all. But thank you for listening to me, and I apologize. I know my voice is kind of quavering, but I'm a little nervous.
No, we're glad to have you up here, Ms. Hood. I don't think that the odds are stacked against you, but I think that on the other hand, many of our committee members have attended a course at Georgia State to look at a problem and not look at just the individual problem, but to look at, if you pass this, then what happens here, and what other problem do we have? And we have a huge drug problem, and we're trying to look at it, not just what is perhaps the most convenient for you to use or inconvenient, for a patient. They might have to use a lesser drug, but might keep that patient from becoming addicted to hydrocodone, and their family and their community and society going through a much broader picture. It's that we are trying to look at the whole picture. And, I have an advanced degree in nursing.
Yes, ma'am.
I know that, at least I did. I went up and picked up morphine for my husband. I went and picked up the prescription from the doctor in writing, and went to get the morphine and picked it up for my husband when he couldn't go and get it. So family members can pick up the hard copy if they have to in that 4 days that somebody is waiting, they can call and get a prescription and go pick it up and get it filled. Is that not right?
Well, a lot of times if they're on the weekends or, say if it's on a Friday night, you're not going to have somebody that's in the office or anything. But
during the week.
But yes, ma'am. But I mean, also I wanted to address like the drug monitoring program. I sign in under my license, and I can look at people, and I have found people that as you speak, and I fully support curbing the medication and accessibility and stuff like that. I've seen people with enormous amounts of medicines that have been written for them, and I don't understand. But I can check those myself. And I do that, and I'm very, diligent about doing that, making sure that it's done.
And what did you do with the people that you found?
I confronted them. I confront them. I'll go in there and I'll tell them. I saw, actually, I had this lady that had 160 hydrocodone written for her within 3 weeks.
Did you call drugs and narcotic and let them know who the patient was the next day?
Well, I can notify the physicians and let them know. But I didn't, I have not notified DEA or anything. But I let the patient know that, this is what I saw that you were written, and you will not get any pain medicine. The best you can do is take Tylenol. And I suggest that you get some help for your drug addiction. And the patients, was not happy with me. And as you know, as an RN, reimbursement a lot of times is based on patient satisfaction and stuff. And, I don't really care if they get mad at me about that. I don't care because I'm not going to hurt them.
No, I think that is a problem. I think you bring up a good point that the doctors, even as the doctors and as a nurse, I think we tend to be pretty tender-hearted with people. I think it's harder for us to say no sometimes about things. And as an employee, as a PA or a nurse practitioner, when they threaten to go to your employer, that's a problem. And I think some people are not like the two of us. I think we're probably much alike and would tell them, go ahead and go. But I think some people worry about it. Even the physicians are saying that the patients are mad and saying they're going to rate them down.
Yes.
And so they're demanding the drugs. And that doesn't make it right. That adds to our problem. But they are now, can be rated down if the patient writes a thing and says they're unhappy with them or unhappy with you.
But,
so,
I don't care, and I can get that. But there is one other thing, and I apologize if I'm taking up
that's
too
all right.
much time, too much
We're
of your
here,
time. The physician has the right to delegate that authority to us as far as any prescriptive privileges. They have that right, and they are responsible for that. And they are still responsible for our patients. I went to Medical College of Georgia years ago when it was Medical College of Georgia. And, we were trained in the medical model. And we still operate under what they want us to do. It's under our physician's discretion.
Okay, we have some schools that are not like the Medical College of Georgia. Have you seen a difference in the kind of PAs and nurse practitioners of their ability, depending on what schools?
Well, I've had both students, when I worked in Tipton especially, I had nurse practitioners and physician assistants. And, the schools are doing pretty good as far as, bringing them out. I think a lot of it is exposure and stuff. And so in Tipton, I was able to give them a lot of exposure. In Lakeland and Quitman, we don't have the big trauma all the time that we did there. But yeah, I think we still are getting out quality. And, I think that a lot of our continuing education is real important. And the PAs, the new PAs and stuff, they're learning that. They go to the conferences and stuff. And we're, in different CME things that you go to, everybody is implementing things like the controlled substances, the narcotics, domestic abuse, sexual assault, and way to do those things. So the continuing education, we support that. I support that.
Do you have to have a college degree to go to PA school?
Yes, ma'am. You have to have a bachelor's degree before you can get in. You sure do.
So, okay.
And you have a master's when you come out. Now, years ago, MCG, yeah.
The old ones. Okay.
I'm sorry.
Thank you very much. Are there any questions for Ms. Hood? Thank you for coming all the way. Thank you very much.
Thank you. I appreciate your time.
Henry Hurd. And for the members, Mr. Hurd is the last person, and I really appreciate you sticking this out. For everybody who has done that, thank you very much. So, wanted to get that in before we dismissed
Thank you very
everybody
much.
after through.
Good afternoon, Madam Chair and ladies and gentlemen of the committee. My name's Hank Hurd. I'm a physician assistant. I graduated Medical College of Georgia in the 3rd class in the dark ages last century, 1976. I practiced in the Atlanta area from Stockbridge to Alpharetta for the last 39 years. My day job right now is I am an assistant clinical professor at Mercer University in the physician assistant program. So originally what I was going to say is thank you very much for sending me the great daughters and sons that you're sending me to Mercer University, because they really are exceptional people. I'm also very fortunate that I'm a retired colonel in the United States Air Force. I was the first full bird colonel in the Air National Guard, and I'm the only PA that I know of that ever got the opportunity and the privilege of commanding an Air Force hospital in Baghdad. So my experience is therefore kind of unique, if you will. So what I was supposed to do is come up again and say, Mercer's a really great university, to take nothing away from the other 3 schools, PA schools. But if I may, change the topic of rah-rahing education and PAs and say that when the federal government changed hydrocodone and made it a Schedule II narcotic, as stated by Representative Kidd, and that's a situation that never should have happened. But the baseline is that chronic pain is different than acute pain, and so acute pain has to be treated acutely. We don't have a good acute pain medicine now that 4,000 of your constituents in Georgia, 4,000 PAs, can use. If any of you fall, break a wrist, have a kidney stone, any something that is as an acute situation, it's Tylenol number 3, or it's Tylenol or ibuprofen. And so our hands are tied. And that's what it boils down to. The patients of Georgia have a problem in that those 4,000 providers don't have the ammunition they need. And so what the medical examiner and what the pharmacy folks have told you today is that basically the FDA was right. There's a problem. There's a huge problem. But by not allowing physicians' assistants the ability to give you the medicines that some of our sick folks in Georgia need at a time is not the right way to go about the problem. The 5 hours for education is a great idea. The 3 hours in the bill that we're discussing is another first step. And all those are good situations. But basically, we need the ability to help. And so the other thing, again, you always have to understand how I work and how I have worked for 39 years is with a physician. If a physician tells me you don't prescribe any class 2s or you prescribe only these drugs in those situations, I have to have the integrity that that's what I do. So if the physician and I decide what we're going to do in certain situations, I don't go outside those things, because the law in Georgia right now as it stands is a physician holds my license. My license is not to the state of Georgia, it is by a doctor. And if the doctor wants to pull my license, he can or she can, depending on my relationship. And so that integrity between what the physician does and what the physician's assistant does, that is primary. So for me, this is just a very simple question. Of course you should vote for this, because it allows the physician to delegate what they want to do and how they want to practice medicine. Now, again, pharmacy and the medical examiner say we got a problem. Well, we obviously do. It's worse in Kentucky, by the way, and Illinois. But when Alabama last year and South Carolina last year both allow for physician assistants, and they're next door to allow Category 2s, then there is some precedence. I know in Georgia we go our own way. So thank you very much, And thank you for your time.
Are there questions for Mr. Hurd? Go ahead.
A real quick question. Thank you, Madam Chairman. So when your physician's assistants were here last week, there were lots of students, Mercer and different ones, and, I was talking to them, and of course they're all about this. I was looking at their youth and exuberance and excitement about being able to really treat folks. It's fun to watch. But I was thinking about when I was looking at them, do you teach them how to say no? Yeah. And how do you teach them that this is an issue and that they've got to look at, as this sweet lady here said, no?
What we do is we teach them a lot of pharmacology, and we teach them from the very first day. In fact, their first semester, they go see patients in the indigent clinic in Good Samaritan and Gwinnett. So they are just going in for a history. Again, what you saw for Mercer, God bless these kids, they're in my physical diagnosis class, and they're first semester students for the most part. So I had to teach them which part of the stethoscope to put in their ears. So it's a little early yet to teach them no, but yes, we definitely work on that, and that is something that's important to the Mercer program, and I'm sure it's important to the other 3 programs. So yes, sir, we try to manage that, but you're right. These kids are so bright, and they're 20s, and so they don't have a life experience that makes different people. But we work very hard on that.
Thank you.
Okay.
Yes, sir.
Dr. Hawkins.
I think you and I are in the same century, and let's go back in time and remember that we used to use Tylenol with codeine, and the limiting factor of that drug, and that's for bad pain. But the limiting factor of that drug was the emetic properties, nausea. And when they developed hydrocodone, all of a sudden the patients could take much more of this drug without the nausea. And there we are in a situation where we are now, where they can take 3, 4, 5 every 6 hours and not endure that nausea. And that's what's really moved it to the Schedule 2. We can still write Tylenol 3. And believe me, that'll kill pain. But, you have to limit yourself or you'll be in the bathroom, right?
Yes, sir. That's absolutely true.
Yeah.
And a lot of patients, quote unquote, as you know, say, "Oh, I'm allergic."
Right.
They're really not allergic.
I hear it every day.
It's like erythromycin. Everybody's allergic to erythromycin because it gives everybody nausea, vomiting.
Right.
So in essence, they're not really allergic. But as you know, the problem is the patient's got to buy what you're selling.
Yeah.
And if what you're selling is a possibility of nausea, vomiting, they're not going to take the pill.
Pretty hard to get addicted to that, isn't it?
You would think.
Yeah.
But I've seen it.
But if you had real pain,
you can take it.
You can take it. That's what we're not hearing here, is that there are other alternatives, and that maybe they're not maybe they don't wipe pain out as effective as hydrocodone does, but the alternative is not as many addicted people. We haven't always had hydrocodone, like Dr. Hawkins says. We have gotten by with Tylenol 3 and other things and not gotten so used to thinking the pills knock out everything. And that's not what I heard from you or from anybody else, that there are alternatives. I haven't had a single person, and I've gotten lots of calls, and I'm usually what I'm hearing from the PAs and the doctors that want this is inconvenient. It's inconvenient. It's inconvenient. It's not about what's best for the patient. And I have yet to have a family call me and tell me that somebody died or they were terribly, because they didn't get it and didn't get a higher drug thing. There's a huge price for families where they get addicted. I went down to talk to one of the reps about a bill, and one of our young lawyers was sitting beside him and piped up and said, and he's not on the committee, "I just got through defending a young man that had an athletic accident," and he said that young man is ruined now. He started with a real accident, was given the drugs, given to him frequently to take care of the pain, became addicted. He just got him for robbing to get Oxycontin, to have the money to get Oxycontin. So there's a price. Somewhere, what we're not hearing is that, okay, it's inconvenient and we want it because we had it. We're not hearing, maybe there be another way to look at this and maybe we ought to reevaluate what we do. It's just a dilemma that we're trying to look at. And hopefully you will go back to your Mercer students and maybe present that as a...
Yes, ma'am, that is a great point. But human nature being what it is, you would always choose the best option. So if you have an option of a better drug that takes your pain away with less nausea, then you would be irresponsible not to try to get that best treatment or best medicine for your patient. I understand that there is education of the patient and the family and the pharmacist. We are a team trying to practice our best medicine. But if I got a good drug, then that's the one I want to use. And right now, I'm limited on certain occasions of giving the best drug.
And I would question, hypothetically, that the best drug might not be the one if it has a high potential for addiction, that would outweigh in my deciding if that was the best drug, whether it masked the pain totally or better, but the addiction problem was higher. And just a way of looking at it in different professions.
Absolutely. And in which
having
case...
having had a husband who took call, who listened to the calls every fifth week all night long, from the addicts calling, from the other doctors, because my husband did an area that didn't have this kind of patients. I know how forceful patients can be, demanding for what they want. It's sort of like mothers and giving their kids antibiotics when they don't really need it because it's a virus, and yet we have people doing it day in and day out, and we have a problem now with infections not responding to antibiotics.
Yes,
Thank
ma'am.
you for coming and testifying.
Thank you.
Oh, do you want one? Do you want the chopper? Go ahead.
Kid had a question.
Okay, Representative Kidd, I'm sorry, I didn't realize it was working. Okay, Representative Sharper, go.
You may get upset when I say this, but
That's all right.
I know you'll get me back one day. But when we look at when we're talking about, they're giving the drugs and we're talking about patient education, it's the same thing when I look at a lot of things. We can do what we need to do and give the patients the medicine, but it's up to them to know what they need to do with it. It's not the drug itself that do it to the patient, it's the patient doing it to themselves, just like people use the same argument that it's not the gun, it's the person with a gun that causes the problem. So therefore, we just got to understand that we need to do what we need to do, but I look at all what we're talking about, but it goes back into helping these patients. It is about the patient. And giving them the best possible drug that they need for their situation is all about the patient, and their hands are tied.
So, Representative Kidd.
Yes, ma'am, thank you. I agree with everything the gentleman said. I do. I agree with everything you said. And I agree with Madam Chairman, there is a legal prescription problem in this state. It's not your fault. It is your boss's fault. It's the physician's fault if they themselves write too many Schedule II prescriptions. It's their fault if they permit you to do certain things that cause a problem. And just maybe by looking at this bill closer, we can find a way to begin to educate them, like in the bill we just passed, and urge them to control you in such a way, or to give you the authority in such a way to ensure the patient doesn't get addicted by mistake of taking a legal drug that's been prescribed. It's not your fault by any means.
Right.
No, it's not the PA's fault. It's the prescribing practitioner, prescribing MD's fault. And the board needs to look closer at regulating them and what they can write and how much they write. Thank you, Madam Chairman.
Thank you very much. And I will tell the committee members there is a letter in your folder from the Georgia chapter of the American College of Physicians against the expansion of the prescribing, so you can find it in your folder. And I do disagree with you, Representative Sharper, because sometimes patients really don't know what all, unfortunately, then they should be more involved, and we should educate them better. Thanks to the committee for coming. Thanks to everybody here. We'll go forward. We'll see what happens to the Senate bill, and thank you very much for your patience.